I want to thank everyone for coming to this session. My name is Priscilla Hsu. I'm from UCSF, and I'm delighted to co-host this along with Sissi Matuluza from Uganda. And this is Non-Communicable Diseases, Continued Challenges. So thank you very much. So with that, we're going to do questions at the end of each talk. And we do have a late breaker, so the timing is a little bit tight for this session. So I'd like to start off with our first presentation. This is presented by Dr. Chris Longenecker, Low Prevalence of Calcified Coronary Plaque Among Ugandans with and Without HIV Infection, Comparison with the United States Cohort and Associations of Biomarkers of Inflammation.
Great, thank you and good morning, and thank you to the conference organizers and the session co-chairs for allowing me to present today on behalf of our study team. And special thank you to people living with HIV in Uganda and in the United States who participated in this research. So over the past 2 decades, there's a large number of epidemiologic studies that have shown that HIV appears to be associated with a higher risk of atherosclerotic cardiovascular disease events such as myocardial infarction. The magnitude of that risk appears to be about 1.5 to 2-fold higher in HIV compared to controls. However, most of those studies, as many in the room know, have been done in the United States and in Europe and Canada, whereas the magnitude of this association of HIV with cardiovascular events in sub-Saharan Africa is really unknown. Attempts have been made to estimate the global burden of HIV-related CVD. This study, led by Anup Shah from the University of Edinburgh, for example, we used UNAIDS and global burden of disease data to show that it appears that the greatest burden of HIV-related CVD may be in sub-Saharan Africa, based on our current estimates, as shown here in age-standardized DALYs per 100,000 persons. However, although these are sophisticated estimates, they are just that. They are estimates and could be improved with better data from sub-Saharan Africa. For example, the GBD models of age-standardized prevalence of ischemic heart disease, pulled here from GBD Compare, would suggest that the US and Uganda have similar age-standardized prevalence of ischemic heart disease. Whether this is true or not is not clear, and we and others are very interested in gathering data from sub-Saharan Africa on this issue. So you can see from this systematic review published last year that there's a growing literature in this field of cardiovascular disease among people living with HIV in sub-Saharan Africa. However, the vast majority of these studies have only evaluated cardiovascular disease risk factors, with relatively fewer studies on surrogate cardiovascular outcomes and even fewer studies on clinical outcomes such as acute coronary syndrome and stroke. And to our knowledge, there are no studies of people living with HIV in sub-Saharan Africa which have used cardiac CT to evaluate subclinical coronary atherosclerosis. And therefore, our study aims are to compare prevalence of calcified coronary plaque between people with and without HIV in Uganda and the United States, and 2, to explore associations of calcified plaque with HIV-specific factors and biomarkers of inflammation and immune activation. Our Ugandan study population consisted of 100 HIV-positive subjects on ART and 100 age and sex-matched uninfected controls, all 45 years of age or older, with at least one risk factor for cardiovascular disease. We compared these Ugandan subjects to Cleveland subjects who have participated in prior research studies of ours, which included 167 HIV-positive on ART and 63 uninfected controls, all over 40 years of age, with additional inclusion and exclusion criteria varying by the parent study. Now, all subjects underwent non-contrast enhanced ECG-gated cardiac CT scan for coronary calcium scoring. The protocols were done on Siemens Samatom scanners and were very similar between Uganda and Cleveland, except that the Uganda scanner was actually a newer 128-slice scanner compared to a 64-slice scanner in Cleveland, and we used 2.5 millimeter axial imaging slices in Uganda compared to 3 millimeter slices in Cleveland. The calcium scores were measured locally by radiologists in Cleveland and Uganda on a Siemens workstation using the Agatston method. For all Ugandan participants, biomarkers of inflammation and immune activation were measured from frozen plasma stored at -80, and then shipped to the United States, where these following assays were performed at the University Hospitals of Cleveland and the University of Vermont. The biomarkers shown there. We performed 4 sets of analyses to evaluate the association of country, HIV status, HIV-related variables, and biomarkers of inflammation with our primary outcome measure of calcium score greater than 0. Using univariable and multivariable adjusted logistic regression models, first building unadjusted models, then minimally adjusted models, which accounted for age and sex, and fully adjusted models, which additionally accounted for diabetes, hypertension, smoking, and total cholesterol. These are the characteristics of study participants. As you can see, there were very significant between country differences, with the red highlight indicating risk factors which may be expected to be associated with higher coronary calcium score. So you can see that Ugandans were older. They had more diabetes and hypertension. They actually had a higher BMI and higher systolic blood pressures as well, despite higher rates of treatment, and higher total cholesterol. Cleveland subjects were more likely to be male, current smokers, and on statin. The between-country differences were less significant. The within-country differences between HIV and HIV negative were less significant than the between-country differences. But for example, with diabetes, the HIV-positive Ugandans were less likely to have diabetes than the HIV negative controls. Here are the characteristics of the HIV-positive participants in Uganda and Cleveland. The Ugandan participants had a slightly lower current CD4 count, but nadir CD4 count was similar between the two, and there was more PI and integrase inhibitor use in Cleveland compared to Uganda. This slide shows our primary findings of this study, and that is that Ugandans had significantly lower coronary artery calcium scores than subjects in Cleveland, divided here, yellow indicating a calcium score of 0, blue score of 1 to 100, and red indicating score greater than 100. For the rest of the analyses, we dichotomized CAC as 0 or greater than 0. So in addition to the between-country difference, the HIV-positive participants in the pooled analyses did have higher calcium scores than the controls. And after adjusting for age, sex, diabetes, hypertension, smoking, and total cholesterol, Ugandans had a 13-fold lower odds of calcium score greater than 0. And in a multivariable model of calcium score among Ugandans only, there did seem to be an effect of HIV. HIV was associated with higher odds, but this was not statistically significant. And in fact, the strongest predictors in this multivariable model of calcium greater than 0 among Ugandans were age, smoking, current smoking, and hypertension. Here you see associations of HIV variables with calcium greater than 0 among all HIV-positive subjects, and the only HIV-specific variable that was associated in fully adjusted models was nadir CD4 count. The associations with biomarkers of inflammation are shown here, and as you can see in the fully adjusted models, biomarkers of inflammation tended to be positively associated with coronary calcium greater than 0, with statistically significant associations seen for soluble ICAM, an endothelial activation marker, soluble CD163, a marker of monocyte activation, and oxidized LDL. Our study has several limitations. First of all, as a cross-sectional study, we cannot prove causal relationships. Secondly, although coronary artery calcium is more strongly predicted with cardiovascular events compared to other surrogate measures like carotid intima media thickness or flow-mediated dilation of the brachial artery, it still is only an estimate of the underlying burden of subclinical coronary disease. Minor differences in our scanners and CT protocol we believe are unlikely to explain the large differences between Uganda and Cleveland. And finally, there were many underlying differences between groups, which increases the possibility of residual confounding. However, on balance, we feel the Ugandans had a higher prevalence of cardiovascular disease risk factors, and we feel this is unlikely to explain our study findings. So in conclusion, despite a high burden of risk factors, this Ugandan cohort of people living with HIV and controls had substantially lower rates of calcified coronary plaque compared to a US cohort. Lower nadir CD4 and higher levels of inflammation and immune activation were associated with CAC greater than 0 among Ugandan subjects. And better imaging studies are now needed, such as CT angiography studies, to further clarify the prevalence of subclinical coronary disease in sub-Saharan African populations, and these are underway. I'd like to thank all of our collaborators and our funders, and especially the study nurses and participants in Cleveland and Uganda. Thank you.
We'd like to open it up for questions. I think while people are coming to the microphone, so Chris, fantastic study, congratulations. I just had a question. It is interesting that the main difference in the study seemed to be whether or not you're from Uganda or not, really not HIV, and that's striking. I was curious, the imaging protocols, were they all read by a centralized center or was done by two? And we know that CAC is not an excellent predictor in the setting of HIV. Have you looked at other imaging modalities? So things like CTA, which it sounds like you're thinking about, or carotid ultrasound.
Absolutely. So to answer your first question, they were read locally by radiologists using the same similar Siemens workstations. And as you know, if you've measured calcium, it's a fairly standardized process. And so we believe that even though they were not measured centrally, that's unlikely to lead to large differences. We are going to go back and reread some of the Uganda studies to make sure. But to your other point, yes, we have started now. We invited this cohort back 2 years after the initial visit and have started performing CT angiograms. So we are now about 100 of these subjects have undergone CT angiography. And so we do expect to be able to look at non-calcified plaque in the future.
Great. Thanks. Microphone 2.
Chris, congratulations on an excellent study.
Thank you.
I have 2 quick questions for you. Your findings in Uganda are very interesting. We're trying to do something similar, and so my question is, in what setting are you? And with specific, in Uganda especially, did you do anything to balance, to make sure that your HIV negative groups are similar in key demographic terms to your HIV positive? Just wondering how you selected your control. Yeah. How much of a control are they?
Yeah, excellent question. So to be clear, these are subjects in and around the city of Kampala and Tebe. So peri-urban tended to be. The HIV positive subjects come from the JCRC, and as I mentioned, were enriched for subjects who were older, who had at least one cardiovascular disease risk factor, which we were able to identify by medical records. We sought the controls from clinics at Zambia Hospital and elsewhere, and they all also had to have a risk factor for cardiovascular disease, so hypertension, diabetes. As you saw in the table 1, they were fairly well matched, actually, the controls, and they were age and sex matched within the study, but then the rates of diabetes and hypertension were actually kind of similar. Yeah, basically hospital-based clinic controls, yes.
So I'm going to go back to microphone 5.
Renzo Shear, Chicago. Do you have any information on the level of control of diabetes and hypertension in the Uganda group? One question. And then it seems like 50% were smokers in Cleveland, and there was almost no smoking in Uganda, and it was driving the result, and it was also twice as many men. Did you look at what the predicted risk factors for both of these groups were, just taking their risk factors, and how your results corresponded?
Yeah, great question. So we don't have any information on diabetes control, although in this 2-year follow-up study we are measuring hemoglobin A1C, so we will know. But to your point, although smoking is associated with higher calcium score and underlying subclinical coronary disease, it is not as strongly associated as you may think. In our Cleveland cohort, there's a modest association. It does not explain the study findings.
All right, microphone 2.
Yeah, a follow-up to the question, the previous question here. In terms, so we've learned that the microbiome can shift between MSM and non-MSM, and that may be impacting systemic disease, CVD in particular. Were you able to control for HIV risk group or other practices that weren't listed?
Great question. In this study, we were not, but something we'll think about for the future.
Right. Microphone 2.
Quick, Peter Rice here in Amsterdam. Great study, and my compliments for doing it. Following up on one of the previous questions, there was quite a high rate of uncontrolled hypertension in Uganda. So my question is, it points a little bit to what Emily Heil said in her plenary about the availability of drugs and what can you do. So is there anything you are planning to do or can do for your study subjects in improving that?
Absolutely. We at the JCRC definitely try to do as much as we can to help subjects be able to afford drugs and to access drugs. But they change all the time. You go to one pharmacy, you might have access to a diuretic one day and not the next, so it's difficult.
Good to actually capture that when you do your follow-up, because it could be an extra message. Thank you.
Thank you.
Thank you. I'd like to move on to the second presentation. So this is presented by Lizanne Demmer, cardiac chamber abnormalities and left ventricular mass in people living with HIV in matched, uninfected controls assessed by multi-detector computed tomography. Thanks.
Yeah, thank you for the introduction. I'm presenting on behalf of the COCOMO study group. And of course, I first want to thank the organizing committee for this great opportunity to present our data. First of all, I want to start this presentation by thanking the people living with HIV who have participated in this research. And these are my disclosures. So, previously studies have found a high prevalence of cardiac abnormalities in people living with HIV, including left atrial enlargement, left ventricular diastolic and systolic dysfunction, right ventricular dilatation and dysfunction, and left ventricular hypertrophy. But only few included a control group. Most of these studies are based on echocardiography, and another method that has proven to be an important clinical tool in patients suspected of cardiovascular disease is multi-detector computed tomography, also called MDCT. MDCT allows a very accurate assessment of cardiac chamber volumes and left ventricular mass, and therefore provide detailed information about potential cardiac structural abnormalities. Cardiac chamber volumes and left ventricular mass provide diagnostic and prognostic information for several heart diseases, and enlargement of these have been associated with poor outcomes. So we aimed using MDCT to assess left atrial volume, left ventricular diastolic volume, right ventricular diastolic volume, and left ventricular mass in people living with HIV and uninfected controls. Furthermore, we aim to determine if HIV was independently associated with cardiac chamber volumes and left ventricular mass. And we hypothesized that people living with HIV have larger cardiac chamber volumes and larger left ventricular mass than controls, and that HIV is independently associated with larger cardiac chamber volumes and left ventricular mass. So, yes. So we designed a study with a cross-sectional design and performed MDCT scans with contrast median in participants from the Copenhagen comorbidity in HIV infection study, also called the COCOMO study. The COCOMO study is a prospective cohort study examining the incidence and prevalence of non-AIDS comorbidity in people living with HIV in Copenhagen, Denmark. Participants from the Copenhagen General Population Study were included as controls and underwent a similar MDCT scan using identical procedures. People living with HIV and controls were matched 1:2. And cardiac chamber volumes and left ventricular mass were indexed to body surface area, as the size of the heart is related to body size. So, using semi-automated MDCT software, we assessed left arterial volume, as illustrated here, and left ventricular diastolic volume, and right ventricular diastolic volume, and left ventricular mass, which was quite easily done with this software. Information about demographics, smoking, and medication was collected using identical questionnaires in both groups. HIV-related parameters were obtained from medical charts of COCOMO participants. Clinical examinations were performed by trained clinical staff using identical protocols, and we also performed the blood analysis measuring lipids and glucose. So, clinical characteristics of our participants, age and sex were similar in both groups. The prevalence of current smokers and cumulative smoking was higher in people living with HIV than controls, but blood pressure was lower in people living with HIV than controls, and there was no major difference in glucose and lipids. Characteristics of people living with HIV, they were predominantly well treated. Mean time with age was around 15 years. 99% were on combinated ART, and 96% had undetectable viral replication. So these are our results of our primary outcomes. And here we found that left-sided absolute and indexed cardiac chamber volumes were smaller in people living with HIV than controls. We found that the indexed right ventricular diastolic volume was larger in people living with HIV than controls, and we did not find any difference in left ventricular mass when indexed to body surface area. Linear regression models adjusted for demographics and cardiac risk factors were used to assess associations between HIV and our primary outcomes. We created two models. One model adjusted for age, sex, body surface area, ancestry, smoking pack years, and systolic blood pressure. And in model 2 with the same variables as in model 1, and then we added non-fasting blood glucose and lipids. And in unadjusted analysis, we found that HIV was associated with 5 milliliter lower left atrial volume, and we found that HIV was associated with 12 milliliter lower left ventricular diastolic volume, and 1 milliliter larger right ventricular diastolic volume, and 4 gram lower left ventricular mass. When we adjusted, we found that HIV was independently associated with 7 milliliters lower left ventricular diastolic volume in both models. We found that HIV was independently associated with 9 milliliters larger right ventricular diastolic volume in model 1 and 12 milliliter larger in model 2. And we found that HIV was independently associated with 4 gram larger left ventricular mass in both models. So, of all cardiac chambers considered, only indexed right ventricular diastolic volume was larger in people living with HIV than controls, and absolute and indexed left-sided cardiac chamber volumes were smaller in people living with HIV. We found that HIV was independently associated with larger right ventricular diastolic volume and larger left ventricular mass, but smaller left ventricular diastolic volume. So we were not able to confirm our hypothesis of larger left-sided cardiac chamber volumes or larger left ventricular mass, but as also previously shown in the COCOMO cohort is that the prevalence of hypertension is higher in controls than people living with HIV, which in part may explain lower left-sided cardiac chamber volumes in people living with HIV. However, association remained robust after adjustment for systolic blood pressure. However, absolute differences were small, and no major structural cardiac abnormalities were found in this well-treated population of people living with HIV. The clinical impact of these differences is uncertain and should be further investigated in prospective trials. I want to acknowledge all our collaborators and my study group, especially my mentor Susanne Dam-Nielsen and Klaus Fuglsang-Kofod, and of course a great thanks to all study subjects for their participation, and thank you for your attention.
Thanks so much. I'd like to open it up for questions. And maybe while people are walking up to the microphone, I want to congratulate you on a terrific study, but maybe I'll start with the first question. So when patients come in for to look at LV chamber size, normally cardiologists would probably send them for an echocardiogram, and that would be considered the gold standard. Could you kind of comment on the ability of a multi-detector CT and how that would compare to ultrasound in this to look at chamber size and LV mass?
So you're asking what the difference or why we are using MDCT, or
how they would compare, because I think some of the findings that you presented are interesting in that they're different than a lot of the ultrasound studies that have been presented. So
yeah.
I'm just curious. Yeah.
I'm sorry. What are you asking? Why? How we are?
I guess I'm just curious as how the assessment of chamber size and mass as assessed by multi-detector CT compares to looking at those same indices by echocardiogram.
Oh, okay. Sorry. Yes.
Sorry. Yep.
Yeah. Well, there have been studies comparing these two, or the two methods, and they have shown that in these kind of stuff like cardiac chamber volumes, this is more accurate MDCT to measure these volumes. I'm a little bit uncertain actually on the ventricular mass, if the MDCT as well is more correctly. Yeah.
Okay, thank you. Microphone 2.
Nice, very nice study, thank you. But I was sitting there thinking that I actually don't know how you recruit your positive subjects for COCOMO. Are these people from different clinics in Copenhagen? Do you have some criteria that apply for them to enter the study?
They were invited to 2 clinics in Copenhagen, and yeah, they were all invited, all in the Copenhagen area.
Okay.
Yeah.
And then you just picked the ones that said yes.
Sorry?
And then you picked the ones that say that consent to be participant. There are no specific criteria other than that they attended 2 clinics.
Yes, that's correct.
Okay. Any other questions?
Over here, Priscilla.
Oh yes, sorry. Microphone 3.
Thanks. You know, a really fascinating study. But what was interesting to me was the right ventricular measurements, and that 9 millimeters of mercury. To your point, I'm much more used to looking at sort of ultrasound measurements. The 9 millimeters of mercury difference looked very big to me. And I'm just wondering, was there more lung disease in the patients with HIV than not?
That's a very interesting question, and we have thought about that as well. And another study conducted in the COCOMO cohort found a higher burden of spirometric abnormalities in people living with HIV than controls. And yeah, we want to look into that to investigate if there is any association between larger indexed right ventricular diastolic volume and this spirometric higher burden or other pulmonary comorbidity.
The other interesting part of that is that the lung is now seen as a big source of inflammation and inflammatory disease. So there might be some interesting correlation there as well.
Yeah, thank you. I think you're right.
Microphone 3.
Hi, hello.
Hello.
Hi, Ken Kunisaki in Minneapolis. So just to follow up on that question about lung disease, I think the other thing that you might consider doing is looking at, particularly for things like pulmonary hypertension with lung disease, it tends to happen more with the emphysema phenotype than the airflow obstruction phenotype. And so one of the things you might even consider would be looking at the limited lung views that you have with your cardiac CT to see if you might be able to estimate emphysema scores and see if that might explain some of that RV dilation. I think that would be an interesting analysis.
Yeah, thank you for that nice comment as well. And we will definitely consider it.
Microphone 3 again.
Thank you so much. It's a really interesting study. I'd like to know if you have also considered other potential confounding factors such as family history of right ventricular hypertrophy or any history of hyperlipidemia that might have also led to these results? Family history or among the cases specifically?
If
it has been kind of addressed in the questionnaire, like previous family history of.
No, but we did just adjust for a lot of cardiac risk factors. But no, we did not look into a family history of cardiac diseases or, yeah. I hope that was the answer to your question.
Thank you. Thanks so much. So let's move on to the third presentation. This is presented by Alan Go. HIV infection independently increases the risk of developing heart failure, the HIV heart study.
Good morning. Thank the organizers as well for this opportunity, and like my colleagues, first I want to acknowledge and thank people living with HIV whose unique contribution to research really benefiting people across the globe. As people with HIV are living longer and thriving, they're exposed to an evolving set of challenges beyond the treatment of HIV infection and AIDS-related illnesses. And toward that end, I'm pleased to share insights from the HIV heart study about the association of HIV infection and the development of heart failure. I have no relevant disclosures. As people know, heart failure is a major public health problem with at least 26 million people known to have heart failure worldwide and about 6 million in the United States, where it remains the leading cause of hospitalization among Medicare beneficiaries nationally and contributes to more than $30 billion in direct costs in 2012. It'll exceed over $70 billion by the year 2030. And with the aging population in the U.S. and worldwide, certainly in the U.S., we expect that heart failure is going to increase by about 50% in terms of population burden, and that represents more than 500,000 new cases in the U.S. alone each year. And with regard to HIV, as I mentioned, we know that people with HIV are living longer with improved therapy, earlier detection, and that's contributing to a shift in the demographics, as we know. In particular, in 2014 in the United States, about 45% of people with HIV were age 50 or older. And with that, we know that in the United States, about 1.2 million people are living with HIV, and as they survive to older ages, they're exposed to important comorbidities such as cancer, chronic liver disease, as well as cardiovascular complications. With regard to complications, a lot of the focus has been on atherosclerotic cardiovascular disease that appears to be attributed, at least in part, to differences in traditional risk factors, the effects of immunosuppression, and possibly different approaches to the use of antiretroviral therapies. So while we know that HIV infection itself is associated with an excess risk of atherosclerotic disease, we know that there's a lot less data about whether or not there's a strong link between HIV infection and heart failure. And importantly, what are potential contributing factors if there is this risk? And so we were interested through the HIV heart study to examine a large, diverse, community-based population to examine whether there is an independent association of HIV infection with developing new heart failure. Our study was based in 3 Kaiser Permanente integrated healthcare delivery systems based in California, in Northern California and Southern California, as well as the Mid-Atlantic states on the East Coast. These integrated systems provide care for about 9.6 million members, both inpatient and outpatient, and most of the care is captured through comprehensive electronic medical records. So our approach was first to identify people with HIV between the years 2000 and 2016 that were found in validated Kaiser Permanente registries. We then identified people who were going to be matched without HIV using a targeted of 1-to-10 ratio, and then from there looked at this matched parallel cohort to see who developed new heart failure based on validated algorithms using diagnostic codes and practice settings that were all found in our electronic health record system. This figure shows you our cohort assembly. On the left side, you can see we started out with 39,000 eligible adults with HIV, and on the right side, almost 13.5 million eligible adults without HIV. From this, we did a targeted 1-to-10 matching based on calendar year of entry into the cohort, age, sex, self-reported race, ethnicity, and the Kaiser Permanente Medical Center where they were receiving treatment. Once we had this cohort, we excluded a small number of patients who had pre-existing known heart failure before the study entry, and when we were left with a final cohort of 38,868 adults with HIV and a matched set of 386,586 adults without HIV. So I'd like to, in the next couple slides, show you baseline characteristics between these matched patients. So what you'll see here is in the orange bars are the adults with HIV, in the blue, adults without HIV. These are the demographic characteristics. As you can see, across age, sex, and race ethnicity, they're extremely well matched. In terms of age, I just want to point out over 20% were aged 50 years or older, 12% women or female, and then in terms of race ethnicity, 21% were Black, African American, over 20% Hispanic, and approximately 4% Asian Pacific Islander. With regard to socioeconomic characteristics, we found that adults with HIV were slightly less likely to have low educational attainment in our cohort, but slightly more likely to have a lower annual household income. Also more likely to have documented illicit drug use, slightly more alcohol abuse, as well as smoking, but these were not statistically significant differences. When we look at medical history, we found that overall prevalent cardiovascular conditions and burden was low in both the adults with HIV and matched adults without HIV, as you can see here in the top several rows. Let me point out some of the main differences we did see. Highlighted in the red box, adults with HIV were more likely to have chronic liver disease, diagnosed dementia, diagnosed depression, and slightly more likely to have known cancer. In contrast, you'll see in the blue box that people with HIV were less likely to have hypertension, known dyslipidemia, or diabetes compared to matched persons without HIV. If you look at the subset of adults with HIV, just to show you some entry information, so at the time of study entry, about 18% were receiving antiretroviral therapy. MSM was the most common route for HIV infection. You see the rest of the distribution of known causes, 24% were unknown. And because this study spans between 2000 and 2016, 43% of patients on entry did not have a known CD4 count, and 76% did not have a known HIV RNA level, and you can see the distribution remaining there. So let me describe briefly the analytic approach that we used. We first looked at rates per 100 person years. Think of it as an annual incidence of developing heart failure by HIV status. And then we were very interested to know whether or not HIV infection was associated with developing heart failure independent of other confounders. So we did a series of what we call nested Cox proportional hazard models, where we consecutively adjusted for any differences in sociodemographic characteristics, cardiovascular disease as risk factors, also major medical comorbidity, longitudinal receipt of cardiac-related medications over time, and finally, whether or not any observed risk at that point was explained by people with HIV having more hospitalized acute coronary syndromes during follow-up. So let's go into the main results here. This slide shows you the cumulative incidence of developing heart failure by HIV status. On the y-axis is the cumulative incidence of heart failure over time. On the x-axis, you can see the follow-up time we had. Adults with HIV, again in orange, adults without HIV matched in blue. And as you can see, adults with HIV had a significantly higher risk throughout the entire follow-up time that was highly statistically significant. When we look at whether or not HIV itself, infection was associated with heart failure, in the first model, after accounting for matching characteristics you see here, there was a 54% increased risk of developing heart failure. When we further adjusted in model 2 for prevalent cardiovascular disease, risk factors, and major morbidity, this strengthened the association up to 69%. When we further adjusted for any differences in longitudinal receipt of prescription medications that may have a cardiac effect, it even further strengthened it to 75%. And then when we adjusted lastly to see whether or not there were differences in the hospitalizations for acute coronary syndrome, you can see it was only modestly attenuated down to 66% increased risk. Now, there have been a number of postulated mechanisms by which HIV may increase the risk of heart failure. This is summarized in this nice figure by Remick and colleagues in 2014. I think while much is unknown, there's really three main areas that have been suggested. First, that HIV itself may lead to a direct damage to the myocyte through a couple mechanisms. In addition, possibly autoimmune or inflammatory myocarditis, also myocardial fibrosis, vascular stiffening, and because of the immunosuppression exposure to both toxic and infectious agents that may further contribute to cardiomyopathy, diastolic dysfunction, and clinical heart failure. Our study was strengthened by studying a large and multi-institutional and diverse in terms of geography, ethnicity, as well as a significant representation of older adults. They were well matched between those living with HIV and those without, as well as a relatively long follow-up. We did our best to ascertain targeted confounding variables, as well as to try to explain possible reasons for why we see an excess risk of heart failure using data from a comprehensive EHR. But we acknowledge the limitations that we had a very limited ability to look at specific pathways, pathophysiologically. Also, our cohort may not be fully generalizable throughout the world due to the fewer supported substance abusers reported, as well as really applying our results most generalizable to the U.S. population who are receiving health care. So in summary, I'll just conclude that we found that HIV infection was independently associated with a higher risk of developing heart failure, and that this excess risk did not appear to be mediated primarily through atherosclerotic cardiovascular disease pathways or any differential receipt of cardiopreventive therapies in either group. We think that it's important to study the potential impact of ART choice on subsequent heart failure risk, as has been suggested by other studies. It's important to continue to do work in potential HIV-specific mechanisms, direct and indirect, that may contribute to heart failure independent of atherosclerotic disease, and to test the effectiveness of strategies that might prevent heart failure or to improve outcomes after the onset of heart failure. With that, I'd like to conclude by thanking all of the research staff, providers, and patients at the Kaiser Permanente in Northern, Southern California, and the Mid-Atlantic states, and the National Heart, Lung, and Blood Institute who provided funding for our study. Thank you very much.
Thank you. I'd like to open it for questions. Microphone 2.
I'm Dominique Cossialiola from Paris. I wonder whether the association that you found between HIV infection and the risk of heart failure was similar in men and women?
Yes, so we did not find any interaction between sex and HIV infection with the risk of heart failure.
Microphone 5.
Paul Sachs from Boston. A very nice study, really well presented. I was struck by how few patients were receiving antiretroviral therapy. I think you said something like 15%. And if you limited your analysis just to those on suppressive ART, would you have seen the same effect?
So it's a good point. So we only took, just reported the status at the time of cohort entry. A much larger proportion over time were exposed to ART. We're in the process of analyzing whether or not exposure to that level of immunosuppression and type of therapy
and
may influence heart failure.
And viremia as well. Okay,
correct.
Thank you.
Thank you.
Microphone 1.
Thank you. Very great, really great study. Was there any consideration for the development of AMI in this patient population in association with the CVD and their HIV status?
Mm-hmm. So what we did in our very last model was to, just to clarify, real quickly, is that we looked at model 4. We actually did adjust for whether or not someone had a hospitalized heart attack or hospitalization for unstable angina. And as you can see, it only modestly affected the association between HIV infection and heart failure.
Thank you.
Mm-hmm. Microphone 3.
Hi, Liz Chow from Baylor College of Medicine. I was wondering if the way that you define heart failure in terms of HIV cohorts tend to have more hospital and clinic visits, and so they are also more likely to, report either symptoms and or have an opportunity to get the different studies that could diagnose heart failure. So did you adjust for follow-up, number of clinic visits, et cetera?
Yeah, I appreciate that question. So what we did is we previously used algorithms which rely on hospitalizations as well as outpatient visits to detect heart failure. For hospitalizations, a primary discharge diagnosis. For outpatients, at least 3 outpatient diagnoses with 1 to a cardiologist. We've done previous manual review to demonstrate you have a high positive predictive value, and it does not appear to vary by HIV status. We also have accounted for differences in resource utilization, not shown here in this model, but that even with accounting for that, it does not explain the difference.
Microphone 2.
Great study. I just wanted to put just something I'm seeing in my data that has also humbled me as I look at some of these questions is that, like me, most people in this room are very biomedically focused. And in our studies in Uganda, where we're looking at individuals stably connected to heart and comparing them to community controls that we've taken a lot of time to find, we are recognizing, and it's actually shocking to me initially, but now makes a lot of sense to some extent, that there's a lot, so especially in the context of HIV, where the social determinants of health, and specifically toxic stress, is so differential with stigma and others. I would encourage you to, it's hard to do in the context of your kind of data, but to keep in mind that toxic stress, and we measured this physiologically using allostatic load, and then measured this psychosocially. We found very strong, striking, dose-dependent differences in adverse outcomes directly related to stress. And then we found that there's strong interactions between them. And so that that interaction, the independent effect of toxic psychosocial stress and physiologic stress, interestingly, psychosocial stress was much stronger. But I just want you to go to think about the impact of stress on this endpoint and the fact that we are so biomedically focused and looking at the mechanisms and the determinants and maybe discounting the power of social determinants in this context.
So I would just say I wholeheartedly agree with you. Not only the issue of stress, social determinants, social support, recognizing things like depressive symptoms as well as other things that could be modified are really important, and they've been understudied, particularly in the context of predicting heart failure. So I think that's a terrific area to explore.
Microphone 5.
Okay. I'm Brian Mizariava from South Africa. Thanks for your presentation. My concept of cardiac failure is it's a syndrome. Okay, cor pulmonale, constrictive pericarditis, all lead to cardiac failure. Systolic dysfunction, diastolic dysfunction here. Were you able, because you just put it as a big group as cardiac failure, and I don't see much in terms of lung disease associated. Is there any sort of issue which goes into the previous presentation with suspicions of cor pulmonale? Were you able to look at that?
Mm-hmm. So it's an excellent question. So we did account for known chronic lung diseases. They, in fact, were not different between the patients in our cohort. I think the other issue of looking at the underlying contributing factors and how they vary for type of heart failure are something we're exploring, not just the EF itself, but other kinds of contributing factors that may contribute to different causes of heart failure. Definitely something we're going to continue to explore. It does not appear to be explained by lung disease or underlying ischemic heart disease as much as well. So we're going to look at other factors. Of course, in the United States versus other countries, there are definitely a different spectrum of the underlying causes of heart failure, as you're suggesting.
And Tokotsubu or stress cardiopathies, as that lady was talking about,
Yep.
could also play a role.
Yes, thank you.
Okay, final question. Microphone 5.
Thank you, Doctor, for the excellent study. As I speak, I feel like wrong man in workers' paradise. I'm neither a scientist nor a doctor. I come from a community experience. I'm Sonal Mehta from India HIV Alliance, and we work with about 1.2 million people living with HIV. And many of them come to us complaining about kind of chest pain and all, and as we refer them, often the physicians say, oh, this is a problem of your ART side effect, and the ART center says, oh, you need to go to the physician. And in this space, often we get too late, and I'm just wondering, would your study come out with some kind of a protocol which is easier for people like me to understand and then refer to the right people to the right place? Or would you be able to recommend what kind of treatment is relevant for what kind of people?
So just quickly, I think that what our study suggests is that there needs to be greater awareness of the possibility of heart failure as an explanation for symptoms that people living with HIV present with. And they can be either traditional or non-traditional symptoms, but I think we have to have great awareness among people who are treating them to do that. And then there are pretty good guidelines, both the national, international guidelines about evaluating for potential heart failure that right now I think we should continue to follow and just have a greater sensitivity because of the excess risk that they face, and also the outcomes after heart failure are generally not very good. Thank you.
I would like now to invite Shriti Shabra. Shabra is a final year medical student at Imperial College London with an interest in HIV and infectious diseases. Shabra is going to present malignancy and all-cause mortality, incidence in teenage young adults living with perinatally acquired HIV. You're welcome.
Thank you very much. Good morning, everyone. I would first of all like to thank the organisers of AIDS 2018 for giving me this opportunity to present this work on behalf of my team. This presentation is actually about a very unique group of youth who were born with HIV and have been living with it for life. So adolescents are the only age group in which HIV-related mortality continues to rise, and there's minimal data on mortality incidence and causation following transition to adult care. And it is known that adults living with HIV are at an increased risk of both AIDS and non-AIDS defining malignancies due to various factors such as immunosuppression and the persistence of oncogenic viruses. And suppressive antiretroviral therapy markedly reduces the risk of certain AIDS-defining malignancies in adults. However, there's very minimal data for perinatally infected youth. In general, youth are also less likely to be retained in care on suppressive antiretroviral therapy compared to adults, with viral suppression rates being as low as 25% in some cohorts. And adolescents, particularly with perinatally acquired HIV, have lifelong exposure to HIV, immune dysregulation, and chronic inflammation, which might increase their risk of acquiring malignancies. A recent study in the UK actually reported rates of non-Hodgkin's lymphoma diagnosis in youth with perinatally acquired HIV to be 25 times that of the age-matched general population. This study, however, only looked at lymphomas, and they did not report any of the treatment outcomes of these youth who were diagnosed with a malignancy. So in youth with perinatally acquired HIV, we aim to describe the all-cause mortality and malignancy incidence rate and compare it to the age-matched UK general population data. We also wanted to describe their HIV-related factors and malignancy diagnosis, as well as malignancy treatment outcomes. So we conducted a retrospective review of all-cause mortality and malignancy diagnosis in youth with perinatally acquired HIV registered at the Imperial College London NHS Trust during a 14-year period between 1st of January 2004 and 31st December 2017. And this was specifically chosen as this would reflect malignancy incidence during the antiretroviral era. And the inclusion criteria were youth aged 10 to 24 years with perinatally acquired HIV, and they had to have a minimum of 2 outpatient appointments. So all youth were followed from the age of 10 if their 10th birthday fell during the study period, or from the start of the study period if they were already at 10 years of age at that point, to the end of the study period, their 25th birthday, death, transfer of care, or loss to follow-up, whichever was sooner. And all data on HIV factors were collected from case records, and they were anonymized. We then calculated the incidence rates for malignancies, lymphomas, and all-cause mortality. And we also collected age-matched UK data on mortality from the UK Office of National Statistics and on malignancy from Cancer Research UK, and calculated the incidence rates in the general UK population, and then compared it to our cohort. So in terms of the overall results, we had 290 youth with perinatally acquired HIV who were registered with the service and met the inclusion criteria, giving a total of 2,644 years of follow-up. During this time, only 2 were lost to follow-up, 14 transferred care, and 6 died. And the causes of death are listed here. So 3 are from malignancy, which I'm going to describe further, 1 from cryptococcal meningitis, and 2 from end-stage HIV and poor adherence to antiretrovirals. So out of the 290 youth, 8 were diagnosed with a malignancy at a median age of 19 years. Most of these were male and most were Black, British, or African. And looking at the overall malignancy diagnosis, so most of these were lymphomas. 3 were non-Hodgkin's lymphoma, 3 with Hodgkin's. 1 youth had hepatocellular carcinoma. He was co-infected with hepatitis B virus as well. And 1 developed GI or biliary adenocarcinoma. And now looking at the incidence rates of mortality and malignancy. So in the first column is the incidence rate in the general population per 1,000 person years, and the second column is incidence rate in youth in our cohort. And as you can see over here, the incidence rate ratio of overall mortality was 9.4, and youth in our cohort were also 13 times more likely during this time period to acquire a malignancy. This was largely driven by lymphomas, particularly non-Hodgkin's lymphoma, as well as Hodgkin's lymphoma. And these are the HIV factors during the malignancy diagnosis. So amongst the 8 youth who were diagnosed with malignancy, the median CD4 count was 453 cells per microliter, with a slightly low median nadir CD4 count of 220. Most importantly, many of these youth actually had the median years of detectable viremia was actually 15 years, which is very high, considering that the median age of malignancy diagnosis was 19 years. And most of these youth had long-standing poor antiretroviral adherence. Half of them had a detectable viral load at malignancy diagnosis, even though all had suppressive antiretroviral regimens available, and antiretroviral therapy and HIV care is completely free of charge in the UK. And now looking at the treatment outcomes. So out of these 8 youth diagnosed with a malignancy, 5 are in remission for a median of 19 months, ranging from 2 months all the way to 14 years. And these are the youth with Hodgkin's lymphoma, the 3 with Hodgkin's lymphoma, 1 with B-cell non-Hodgkin's, and 1 with Burkitt's lymphoma. Just interestingly, one of the youth with Hodgkin's lymphoma actually had 2 relapses. He initially underwent chemotherapy, after which he relapsed. He then underwent an autologous stem cell transplant and then relapsed again. And then he has undergone a bone marrow transplant with a maternal donor and is currently in remission. Unfortunately, 3 of the youth with malignancy have died, 1 with B-cell non-Hodgkin's lymphoma, 1 with GI adenocarcinoma, and the youth with hepatocellular carcinoma. Also interestingly, the youth with hepatocellular carcinoma had been completely suppressed of HIV and hepatitis B for over a decade before he was diagnosed. So overall, malignancies accounted for 50% of all deaths in our cohort, and the remainder were associated with poor adherence to antiretroviral therapy and end-stage HIV or AIDS events. And in the UK, 15 to 24-year-olds, actually, only 12% of deaths are attributed to cancers, with most of deaths being attributed to external causes such as accidents and poisoning. And in terms of treatment outcomes, results in adults living with HIV and a lymphoma suggest survival rates approaching HIV-negative population. But it is known that even amongst HIV-infected youth, youth in general have poorer overall cancer survival rates compared to younger children. And the numbers in our cohort are quite small to actually make any definitive conclusions, but more than a third of the youth who had a malignancy died due to advancement of their malignancy, suggesting that they might possibly have poor treatment outcomes as well. So the strength of our study is that we had very good follow-up rates during the study period with less than 1% lost follow-up, which is a rarity in a cohort of this age group. And it also adds to the very limited data that's available on malignancies and treatment outcomes, particularly in youth with perinatally acquired HIV. However, we have a very small absolute number of cases, and much larger studies disaggregated by age and route of transmission are required to actually understand the risk of malignancy and mortality in this population. And our cohort was not matched to the general population in terms of traditional cancer risk factors and socioeconomic factors, but these are less likely to have an impact on malignancies in youth and tend to affect older adults more. So in summary, in our cohort, the incidence rate of death was 9 times, and that of malignancy was nearly 13 times that of the age-matched UK general population. Most youth with perinatally acquired HIV and malignancy had a low nadir CD4 count and many years of sustained HIV viremia. And it is therefore hoped that with early sustained suppressive antiretroviral therapy, this excess risk of malignancy in this cohort will reduce. And what we're seeing in the UK is what we actually suspect that we might see in other countries, as we have this unique cohort of perinatally acquired children with perinatally acquired HIV growing into adolescents and young adults. And we really hope that there will be better measures to actually support these youth in ensuring that they get good antiretroviral treatment and they adhere to their regimens. So thank you very much. I would really like to thank the youth and the families in our cohort, my supervisor, Dr. Caroline Foster, for her guidance and support in completing this study, and all the authors for their contribution and help.
Thank you very much. We'll now open up for questions. I think this is a very good study, and many of us in this audience have adolescents that we are looking after. And just besides having high viral load because of non-adherence, these are some of the complications these adolescents can get. So I think this is very good, and we have messages to take back home. Yes, microphone 6.
Sorry, my question is regarding adherence. Large majority of these adolescents were non-adherent to ART therapy, and yet they had a good follow-up in the study. Were any of the deaths in the study attributed to poor adherence to treatment? There are, this one.
So the deaths in terms of the deaths in, as we showed, out of the 6 youth who actually died overall during the study period, 2 of them died due to poor antiretroviral adherence as well. And even the youth who died of cryptococcal meningitis had a low CD4 count and poor adherence. So actually half of them had poor adherence. And this is actually a big challenge in this adolescent population, because they're going through a lot of social and psychological changes during this time, and a lot of them are coming to terms with the fact that they're living with this chronic condition, and many of them actually also suffer from mental health issues, which makes adherence a challenge.
Okay, microphone 1.
That was an excellent talk. I may have missed this, and I apologize if I did, but did you have information on cancer stage? And did you see, were there differences in stage between the youth with HIV and those without?
So, yes, we did look at the cancer stages, although the thing is that the overall number of cases are quite small to make any sort of comparisons whether the youth with HIV present with more advanced disease or not. But out of the 6 youth who presented with lymphoma, 4 of them had Ann Arbor stage 3 or 4 disease, so they were pretty advanced stage. And the youth who presented with hepatocellular carcinoma had eventually developed disseminated disease as well as the youth with GI adeno. So most of them actually had very advanced disease.
receive standard therapy, particularly for the lymphomas? Were they given what you would give as a standard regimen for a non-HIV positive person?
Actually, in terms of the treatment, I haven't been personally involved in looking after these children, but my supervisor is here who's actually looked after them, so I think she might be able to answer in terms of the treatment regimen.
Had fairly standard regimens, but I think that the main message of this is that the first 4 or 5 young people to present with a malignancy presented with very advanced disease. And actually, as our sort of antennae have gone up, the diagnosis of the last 3 have been very rapid with less advanced disease. But generally, the chemotherapy, complicated by the use of boosted PIs, in that some of them are on 3rd and 4th line therapy, helped by the integrase inhibitors. And interestingly, obviously, the young man who has had a maternal donor, he has the same virus as his mother. And therefore, and that's been some ethical challenges. And the other point that we have learned is that they weren't being offered sperm donating before they had their chemotherapy in the early years because of their HIV status. And I think we've managed to change that practice.
Thank you.
Thank you. Thank you. Sure, you can. Our next presenter is Evelyn Verheij from the Netherlands. She's an MD, and she's currently pursuing her PhD in aging with HIV. Evelyn, you're welcome.
Thank you. I want to present to you today our research done within the HIV study, and I've looked at frailty and the risk of mortality, incident comorbidity, and have also looked whether people living with HIV are of increased risk of progression to frailty. It is well recognized today that people living with HIV getting older, but they still remain at increased risk of age-associated outcomes, including frailty. And frailty is a syndrome of increased vulnerability to these adverse health outcomes, such as falls, hospitalization, and mortality. We assessed the frailty score as defined by Fried, and we looked at low gait speed, slow gait speed, low grip strength, self-reported exhaustion, low physical activity, and weight loss. And we considered people frail when they had 3 or more criteria. You were pre-frail if you had 1 or 2 criteria, and you were robust if you had 0 criteria. And the aim of our study was to determine the impact of frailty on all-cause mortality and comorbidity development, and also to determine the impact of HIV infection on progression to frailty. So the methods. So people could contribute to 3 study visits 2 years apart. So we started in 2010 and we are still continuing this research, but I share data until the 3rd study visit in 2016. So the first analysis, I included all participants who started during the study at visit 1, and I looked whether they died during the follow-up period, and I used Kaplan-Meier estimate and multivariable Cox regression. The second analysis, I looked at whether these participants developed comorbidities. So in order to do that, the participants had to participate in 1 consecutive study visit. So you can see that I have slightly decreased number of participants in this study. And I use multivariable logistic regression with generalized estimated equations to account for correlated observations as participants could contribute to multiple study visits. And last analysis is about progression to frailty versus people who remained robust and whether HIV infection has an impact on this. So if you look at the number of participants, it's a subgroup because I had to compare participants who progressed to frailty and compare them with participants who remained robust. And I also use logistic regression. So the HIV cohort is an ongoing study and included HIV negatives from the Public Health Center of Amsterdam. And the HIV positive participants were included at the Academical Medical Center of Amsterdam, and they were all 45 years of age or older. So the HIV cohort, the median age was 52, and they're most consisted mostly of men who have sex with men. Whether the HIV negatives were most often of Dutch origin and received higher education, and the HIV positives had a higher waist-to-hip ratio, more often depressive symptoms, and a higher number of comorbidities at baseline. So the positive population were diagnosed with HIV 12 years prior to enrollment, and most of them received ART about a decade prior to enrollment. And although their CD4 count was almost 600 cells, they had a CD4 nadir for less than 200 prior to in their history, and about 1/3 had a history of AIDS. So if you can see from this figure in red and in blue is that frailty and pre-frailty prevalence increased, as you can expect, with age. And you can also see that the HIV positives on the right had a higher prevalence of frailty compared to the HIV negatives on the left by age groups. So the frailty prevalence at baseline was around 10% in the HIV positives and 3% in the HIV negatives. On to the results. The first result is about frailty and risk for mortality. And in this follow-up time, 5 participants who were HIV negative died, and 12 participants who were HIV positive died. So this is a relatively low mortality rate, but you can see that frailty, as shown in the red line in this Kaplan-Meier, predicts mortality. And if we look at this Koch regression about frailty and mortality, you can see that frailty is associated with an increased risk of mortality. And if you adjust for HIV infection, age, and number of comorbidities, this association does not change. Looking at the second analysis between frailty and incident comorbidity development, we observed 329 comorbidities in almost 400 person years of follow-up. And you can see that in 75%, it consists of hypertension, COPD, renal disease, and osteoporosis. And these diagnoses did not differ by HIV status. So looking at this multivariable logistic regression picture, you can see that frailty is associated with an increased risk of almost 3-fold on developing comorbidities. And adjusting for HIV status and age, and further adjusting for risk group, ethnicity, and education attenuates this relationship, but still, frailty stays independently associated with an increased risk of comorbidity development. Looking at our last analysis, I want to recap the method I used. So people could contribute to multiple study visits, and I compared participants who progressed to frailty from a non-frail status to participants who remained robust. So I have almost 200 HIV positives and I have almost 300 HIV negatives participating in this analysis. And what you can see is that HIV infection is associated with an increased risk of progression to frailty. And if I adjust for age, risk group, ethnicity, and education, it does not change. And adding waist-to-hip ratio did attenuate the association slightly, but adding number of comorbidities and depressive symptoms does attenuate this relationship. So in conclusion, frailty was more prevalent among middle-aged HIV-positive participants in our study, and frailty had a strong impact on both mortality and comorbidity development, and this was independent of HIV status. Also, treated HIV disease increased the risk of progression to frailty, and this was mainly mediated by a higher number of comorbidities and depressive symptoms. So I want to thank everyone on these slides, and especially our study participants, and I'm happy to take questions.
Thank you for an excellent study. I think this is something that we could put as screening in our clinics of our patients so that we can determine and sort of identify comorbidities before they even get advanced. Microphone 2.
Speaking particularly of somebody who is infected with HIV, if they are frail, Are there any interventions that could be used to address that?
Thank you for your question. Yeah, I've done a lot of literature research on useful intervention when people are frail. And I think the first part is recognizing people who are at risk of progression to frailty, because when you are robust, you see that people stay robust in a bigger amount more often. So if you have pre-frailty and you are frail, you are more likely to stay frail. But there are interventions being done like physiotherapy, smoking cessation, social networks in order to help people from frailty to their robust status. Yes.
Microphone 5.
Sheer from Chicago. Thanks for that great study. Frailty's been associated clearly with morbidity and mortality, but only in people over age 80, and it's never been associated with HIV that I know. So this is really an important study. 30% of your enrollees had AIDS, and that might actually be quite important. Can you describe the opportunistic infections? Were there more CNS infections that might be more predisposed to limited mobility? And then just adding to that last question, mobility and exercise as the key to countering frailty is so key. Thanks again.
Yeah. Thank you for your question and for your last remark. I think you're absolutely right. I've looked whether opportunistic infection in our population was also associated with progression to frailty and also comorbidity development, and I could not find any association with that. Although I did find in the analysis that people who have had a period of immunosuppression were more likely to develop comorbidities, but they were not more likely to progress to frailty, and possibly because they were already frail. And I also looked at that, and I could not find that in our population.
Microphone 1.
Thank you. That's an incredible study, David Miller, United States. There's a definitive body of peer-reviewed literature, right, that's emerging now that shows correlations between the emergence of GI comorbidities, Crohn's, that may be totally disassociated from HIV, like Crohn's disease, IBS, ulcerative colitis, in HIV patients who are treatment experienced with disease progression towards frailty. Is there any way to extrapolate whether or not any of the patients in this really great study had any of those risk factors for GI comorbidities?
Thank you. I've looked at non-AIDS malignancies, but I haven't particularly looked at GI malignancies in this study, so I'm not sure. Thank you.
Microphone 6.
Alan Landes, Chicago, a very nice study. Have you also looked, there's been a number of inflammatory biomarkers associated with frailty measures and a number of the comorbid outcomes. Do you have additional data on predictors of serum biomarkers of inflammation and the outcomes or microbial translocation?
Thank you. Yes, because I had only 10 minutes, I did not include that in my slides, but I did look at IL-6, D-dimer, CRP, soluble CD14, soluble CD163, and intestinal fatty acid binding protein. And I could not find any association between them and progression to frailty, or between them and having had an increased risk of comorbidity development. I'm not sure why that is in my population, but possibly because of our negative control group being very comparable. So I haven't found it.
Thank you.
And finally, microphone 2.
Thank you for such a great talk. This is such an excellent session. So in our study, we've looked at frailty, and I recognize that, we've looked at frailty and HIV positive and negative controls. Again, sounded like a broken record, but one of the, with respect to frailty in particular, and to verify the point that this gentleman living with HIV raised, we set out to try to think about, so what do? We have this hypothesis, and we're building evidence towards intervention, we hope. And so we tried to find opportunities for modifiable risk factors. And it was very humbling for me to see how much of what the dependence of how HIV positives progress to frailty, or the odds of frailty in relation to psychosocial stress. even stronger than physiologic stress when you combine 13 biomarkers. So I'm trained very biomedically, and all the gut dysbiosis, they all play a role, but something is very differential with respect to the vulnerability in the context of stress. Now, I'm in Uganda, but I'm not convinced that toxic psychosocial stress is that dramatically different, whether you are in the UK, even the best world situation versus in Uganda, because we're just seeing such a profound role of toxic stress both in children living long with HIV, so older adolescents, and the interaction with HIV is fascinating. So,
thank you. Okay, thank you. And last but not least, please don't leave, is Susan Crown. Susan Crown is a medical oncologist interested in HIV-associated malignancies. She's a member of the leadership group of the AIDS Malignancy Consortium, a National Cancer Institute-financed cooperative group conducting clinical trials in the US and abroad. Today she's presenting superiority of paclitaxel compared to either bleomycin or vincristine, or etoposide as initial chemotherapy for advanced AIDS, Kaposi sarcoma in resource-limited settings. This is a multinational randomized trial of the ACTG and AIDS Malignancy Consortium. Susan, you're welcome.
Great, thanks. Here's the presentation from the frail elderly. Okay, so on behalf of my co-chair, Margaret Borak, who's over there, and the rest of the study team, I'd like to acknowledge and thank the people living with HIV who generously participated in this research, and the meeting organizers for giving us the opportunity to present a 5263 AMC 066, which was a joint venture of this is a joint venture of two NIH-funded clinical trials groups, the AIDS Malignancy Consortium and the AIDS Clinical Trials Group. Kaposi sarcoma has long been a significant contributor to morbidity and mortality among people living with HIV in resource-limited settings, particularly in sub-Saharan Africa, where over 95% of participants in this study were accrued. It may present along a continuum from mild to advanced and potentially life-threatening disease, and is considered to require ART for its optimal management. In people with advanced KS, it is generally accepted that chemotherapy is also required, but there's no evidence-based standard for what represents optimal chemotherapy in this setting. And thus, a well-designed clinical trial was considered essential to inform treatment guidelines. On this slide, I've summarized various factors that need consideration in the choice of chemotherapeutic agents in HIV-positive people. And these include anti-tumor activity, effects on quality of life, and potentially on ART adherence, potential interactions with other drugs, including ART, ease of administration in areas where chemotherapy treatment infrastructure may be scarce, and cost. On this slide, I've listed some of the potential benefits and risks of the 3 chemotherapy regimens we tested in this study. And notably, etoposide is the only agent available in an oral formulation, whereas the combination of bleomycin and vincristine is considered a standard regimen in many resource-limited settings. It has limited hematologic toxicity and is fairly inexpensive and widely available. Paclitaxel, on the other hand, is one of only 2 currently available US FDA-approved chemotherapeutic agents for KS. And it's highly effective, but was not widely available in resource-limited settings at the time we started the trial. And of course, on the negative side, each of the regimens has its own unique toxicities and the potential for drug-drug interactions. And so our study was designed as a prospective, randomized, active-controlled, 3-arm clinical trial with randomization stratified by country and baseline CD4 count. 3 regimens were used: oral etoposide plus ART, bleomycin and vincristine plus ART, and paclitaxel plus ART. And the study was designed to evaluate if there was sufficient evidence to conclude that each of the first 2 regimens, which were considered investigational, was non-inferior to paclitaxel plus ART, which was considered the active control. And non-inferiority was defined as demonstrating that the clinical efficacy rate in the investigational arms, which was measured as progression-free survival, was within 15% of the efficacy rate in the paclitaxel arm. And the original sample size of 706 gave 88% power to demonstrate non-inferiority, assuming that the true progression-free survival rate in each arm was 65%, which was based on an earlier AIDS malignancy consortium trial performed in the US. Eligible participants were adults with confirmed HIV infection, limited or no ART exposure, biopsy-proven KS, and no prior KS treatment. The initial allowed duration of prior ART was 28 days, but this was increased to 42 days in 2015. All participants had advanced T1 stage KS, which included one or more of the following features, which were symptomatic edema, tumor ulceration, extensive oral KS, and visceral KS. And participants had to have measurable cutaneous KS lesions that could be followed serially, and clinical features that would allow the safe administration of chemotherapy. And so briefly, participants were randomized equally to one of the 3 arms in step 1 and received 6 cycles of chemotherapy with ART, which was a triplet unless there were specific contraindications. And those who had a durable response to step 1 chemotherapy who later showed KS progression could receive a second course of the same chemotherapy in step 2, but those who did not respond or who showed KS progression after a brief period of response could go on to receive alternative chemotherapy regimens in step 3 and step 4. The primary endpoint was progression-free survival through week 48, which was defined as lack of KS progression, death, entry to another step, or loss to follow-up. And the primary analysis involved constructing the 95% confidence interval for the difference in progression-free survival between the treatment arms and examining if the confidence interval excluded the 15% non-inferiority margin. Interim analyses were conducted at each DSMB review, and the confidence interval size was based on the statistical information available at the time of the review. And predicted interval plots were used to assess the power at the end of the study given current trends. The study timeline this is moving by itself. The study timeline is shown here, and although version 1 of the protocol was approved in 2010, for various reasons, accrual did not begin until late 2013, and rollout of sites then occurred gradually because of the need to enhance the chemotherapy treatment capacity at many of the sites. At the 3rd DSMB review in March 2016, the DSMB recommended closure of the etoposide arm based on the primary endpoint analysis. And this led to a revision of the study as a two-arm comparison with a sample size of 386 with 80% power to demonstrate non-inferiority. And then accrual continued until March of this year, at which time the DSMB recommended stopping the study based on the analysis of progression-free survival in the 257 participants randomized to the remaining two study arms. Briefly, baseline characteristics were similar for participants in the three arms, with the exception that those randomized to etoposide, many of whom were entered prior to increasing the allowable duration of prior ART, were less likely to have a suppressed HIV viral load than those in the other two arms. Kaplan-Meier plots for progression-free survival for each of the treatment groups at the time of the last DSMB review prior to arm closure are shown in this slide. For the etoposide versus paclitaxel comparison, the difference at the time of the analysis was 39.4%, which far exceeded the 25% threshold the team considered excessive. For the BV versus paclitaxel comparison, there was a 20% difference in progression-free survival. Predictive models showed a low chance of demonstrating non-inferiority, and this was not likely to change. And the decision to stop the study and make paclitaxel available to all eligible participants was supported by an ad hoc analysis that showed a better response when paclitaxel was given as second-line therapy than when BV followed paclitaxel. Targeted grade 3 or greater toxicities were as expected and similar in each arm. CD4 counts increased similarly from baseline in each arm, and HIV RNA suppression was not prevented by the concomitant administration of chemotherapy. So in conclusion, this study establishes paclitaxel with ART as a standard of care for initial treatment of advanced AIDS-KS in resource-limited settings, leading to increased progression-free survival compared to either a commonly used intravenous BV regimen or an oral etoposide regimen without sacrificing safety, CD4 count recovery, or HIV RNA suppression. We still have many analyses to conduct of various clinical and laboratory secondary endpoints, and are also awaiting the results of a PK interaction sub-study. And we're also discussing the possibility of a post hoc cost effectiveness analysis, particularly now that paclitaxel is much more widely available than when we started the study, and in many cases the price has come down significantly. And finally, I think our findings underscore the need to improve cancer therapeutic infrastructure and the accessibility of cancer treatments in resource-limited settings. So many people contributed to this study, and on behalf of the study leadership, I'd like to thank them all, and I'll leave this slide up while I take your questions.
Thank you, Susan, for this very interesting study. We'll open up for questions, but maybe the first question I have is, how much is paclitaxel, the price, compared to bleomycin?
It depends.
Which we are already using, or are there any generic manufacturers?
It really depends upon where you are. I know from my co-chair, Margaret, that paclitaxel is probably 2 to 3 times as expensive in Zimbabwe as the BV regimen. I'm told by some of our colleagues in Cape Town that currently the price of paclitaxel is less than that for BV. So I think the price is really a moving target. I think one of the things that is important to note is that some of the initiatives for supplying low-cost cancer drugs in Africa include paclitaxel as well as bleomycin vincristine and etoposide. And so I expect that, that paclitaxel will be more widely available at a reasonable cost.
Okay, slide 5.
Samir. Indianapolis, beautiful trial, and I'm sorry if I missed this. Did you capture in the trial KS-associated iris events?
Yes, actually, we defined suspected KS iris in this study, which had to occur within the first 12 weeks and be associated with certain other changes in either CD4 count or HIV viral load. And interestingly, there were extraordinarily few events that met the KS iris definition. And this is entirely consistent with data that Tom Campbell has presented on sort of a sister study of less advanced KS where participants were randomized to either ART alone or ART plus etoposide, and the etoposide arm participants showed a very, very low rate of KS iris. So I think that even the least successful chemotherapy drug in this study in that other study markedly reduced the incidence of early iris events.
Yes, microphone 5.
Yeah, Sylvain Kutzen, Doctors Without Borders in South Africa. Thank you for giving some increased clarity on standard of care for Kaposi sarcoma, which is very much needed. You didn't mention liposomal doxorubicin at all, which is the first-line treatment in the majority of rich settings. So why did you not include it as an additional arm in this trial? And how do you see the role of liposomal doxorubicin in resource-limited settings?
Well, great question. And actually, I didn't go into the details of why version 1 of the protocol was ready in 2010 and why we didn't actually enter patients until 2013. But our original plan was to use liposomal doxorubicin as the control arm. And just when we were getting ready to begin the study, the entire world supply of liposomal doxorubicin disappeared, and so we had to choose an alternative. I actually think that that was a good thing because I think it was important that we studied paclitaxel, but we're now talking about doing a comparative study, including a very formal cost-effectiveness analysis looking at paclitaxel versus liposomal doxorubicin. Currently there are generic pegylated liposomal doxorubicin preparations available. They're still far more expensive than paclitaxel, and so we are talking about that kind of comparison now. But yes, the reason that we didn't look at liposomal doxorubicin was that the entire world supply disappeared.
Thank you.
Last, yes.
I just wanted to make a comment on the paclitaxel supply. There is a generic available, and it is on the WHO required medicines list, and it's expected and hoped, very much hoped, that the results of this study will improve access to that drug. In terms of again, another comment about the liposomal doxorubicin. One of the kind of thinking that we had behind the study was that if there was such short supply of the drug that we couldn't even do a research trial, then it would not be a practical solution for resource-limited settings.
Yeah. Well, thanks, Katie. But I just want to emphasize that all of the drugs that we used are on the WHO essential drug list, but are listed as complementary medicines, which means that you need the infrastructure and trained personnel to safely administer them. So I think it's a combination both of drug availability as well as the infrastructure and training necessary to safely administer chemotherapy.
Thank you. That's good news about the generic manufacturing. Microphone number 5.
Beyer, Radboud University, the Netherlands. I was wondering, of course you mentioned the PK results still have to follow, but do you expect any effects of drug-drug interactions on outcomes, especially given the fact that we're going to switch from atripla to dolutegravir?
No, actually, I don't. If you look at the rates of HIV RNA suppression, I don't think that there's any good evidence that co-administration of the chemotherapy impaired the efficacy of the ART and vice versa. And in fact, it's very interesting that the 63% progression-free survival that we saw in the paclitaxel arm at week 48 is almost identical to the 65% that we hypothesized based on a prior study. So I don't think that we have any evidence that the ART negatively impacted the effects of the chemotherapy either.
I'd like to say thank you to all our presenters, very excellent presentations, and to all of you for coming to this session and learning more about what we can do for HIV patients, other comorbidities that they may have, how to screen and also how to manage them better. You're very welcome.